Next will be one of our local faculty, Major William Carlton from Triple Army Medical Center. He'll give us an overview on adult thoracolumbar trauma.
All right, so yeah, to piggyback on the end of the talk we just heard, so I'm a neurosurgeon that was trained at University of Florida, just finishing up my first year out of practice. So this is all kind of straightforward adult stuff. I practice at Tripler, so the pink hospital you can see off the H3. So my patient population is active duty service members, their dependents, also veterans. That's kind of most of what we do. No conflicts of interest to disclose. These are my views, not the Department of Defense. So thoracolumbar spine fractures account for, some would say, about 90% of all spinal fractures. Of that number, most occur from fall from height, although in my experience it seems like more come from traffic accidents. Either way, it's pretty close, and those are the overwhelming majority. So just like someone I saw recently, just to kickstart the thinking about it, this could be, sure, fall from stairs or jump from a helicopter or from an obstacle course accident or something like that. Back pain, they come to your clinic, they have this, this scan, what do you do? And so a big part of our training is just framing how you approach these kind of bread and butter fractures. This is not advancing. Oh, there it goes. When I was early on in residency, we talked a lot about T-Lex scores, and I think when you're out in practice, you've gotten so familiar with these various scoring systems that you don't even think about a number. You just kind of look at a scan and you say, yes, this is stable. No, this is not stable. But early on in training, I think it's really helpful for kind of putting together your approach. So T-Lex is what we've used, and it breaks it down. I'm sure most of you are familiar with this, of course. Morphology, the integrity of the posterior ligamentous complex, and then what's the patient's neurologic status. There was, so of course, compression fractures, then bursts for anterior middle column injury, translation rotation, and it's just escalating point of instability, and then it came with a kind of a scoring system for whether they think there's non-surgical versus surgical versus kind of gray area, and distraction being in this scoring system the most disruptive. While I was in training, AO Spine came out with their classification system, and it was equivalent for the most part. The main difference was that rather than requiring an MRI to determine whether posterior ligamentous complex is injured, they included this modifier where you can kind of just look at a CT scanner and say, yeah, probably is, probably isn't, and that can be added to the score. Otherwise, they spread out the morphology a little bit. For instance, you have an incomplete burst versus a complete burst fracture. But all in all, the two scoring systems, kind of similar idea, help you conceptually formulate a determination of whether or not something's stable. So you are presented with a case and you decide, well, this is unstable, I think it needs surgery. Then there's the, of course, considerations of, well, what do you do? How many levels are needed here? What's this fracture? Where is it relative to the thoracolumbar junction, cervicothoracic, lumbosacral? Is this going to be a 360? Can this be done effectively posterior alone, anterior alone? And then are there any other kind of metabolic factors? Dish, ankylosing spondylitis, that sort of thing. So when presented with a operative situation, what we would like to talk about a lot, where I trained, was the load sharing classification, because it helps you decide, can this be a one up, one down operation, or is this something where that is more likely to fail from biomechanics standpoint? Can I trust that the anterior middle column are going to support a posterior stabilization, or do I need more points of fixation to share the load? So of course, paper 94 from McCormick that kind of followed 28 patients who had one up, one down after a 3-column thoracolumbar injury. 10 of them developed a hardware failure, so then they created this classification to predict who failed, who wouldn't fail for going forward. And the gist of it was how much of the vertebral body was disrupted, if in an axial section, how much of the fragments are spreading, and then from a deformity standpoint, how kyphotic are they? Now, in their paper, the angulation part of it was kind of an after-the-fact point. So after I've done surgery, how much correction did I get? Whereas in practice, the way we kind of use it, or the way I use it, is how much am I expecting to get, and that would then affect my approach. That being, and the reason I say that is because that looked at one up, one down after an injury, but if you know ahead of time, well, if I do a longer construct posteriorly, could I avoid hardware failure? So other people have looked at doing a longer construct posteriorly, adding more points of contact, and this is just one of those papers that subsequently said, no, you do not need to do an anterior column approach as well. So brief run through, sped through it. Obviously, most of y'all are very familiar with this stuff. So 19-year-old, severe low back pain after an MVC. CT scan showed a burst fracture at L5, and the patient had bilateral EHL weakness. It was an axial and sagittal over CT scan, so it had fragment retropulse, not too much of angulation. AO spine would say that's 5 points because it's an incomplete burst fracture with nerve root disruption. So 5 points, that's a surgeon's choice. T-Lex would say that's a 4 with an asterisk because I didn't have an MRI, so burst fracture plus neurologic dysfunction. So I looked at it, and then you had the load sharing classification score was 6 being, you could probably do one up, one down and be fine. And again, conceptually, that's what I did. I said, all right, well, I think this should be fine, safe to do a one up, one down. It just, that made my approach. So next case, a 49-year-old fall from height, severe low back pain, right lower extremity pain. This one had an L4 burst fracture, but then there was some other stuff. L1 compression fracture, L5 spondy, degenerative spondylolisthesis. It's full strength on exam, but had leg pain. So this is where you have shortcomings of these classification systems in a sense. I mean, it says, I can say that the L4 burst fracture looks unstable. It's more complete. Again, retropulse fragments. And as I'll talk about load sharing classification for this one, would say, probably 2 up, 2 down would be most appropriate. But then you look at the rest of the spine. I have the L1 compression fracture and obviously the spondy to factor in. Do I want to end a construct adjacent to that compression fracture? I elected not to. Well, I'll show you the x-ray in a second. So AO spine would give it a score of 6. That's a complete burst fracture. Again, nerve root dysfunction from radiating leg pain. So that would point you to say, okay, this is operative. T-Lex, in this case, would say 4, again, without an MRI to evaluate posterior ligamentous complex. Load sharing classification would give me a 7 if you add it up. So again, this would argue for either 2 up, 2 down, or staged posterior 1 up, 1 down with the corpectomy to follow. So elected to do, treat the degen spondy with a T-LIF, instrument, if you can, the fracture, and then rather than go 2 up because of that compression fracture, stop 1 above. So, some may disagree with that plan, but it was, again, guided by these scoring systems that I trained under that we use. Another case, this is a 46-year-old who was hanging from a deer stand, fell 30 feet, severe low back pain, unable to stand, had a severely comminuted L3 fracture. That we'll see had iliopsoas weakness, leg pain. So again, complete burst fracture, this time at L3. A lot of retropulsion. Surprised he was as strong as he was. We've all seen scans like that in this context. No question there's posterior ligamentous disruption. I mean, even the spinous process at L4 is completely split, so it just suggests it's disrupted. Didn't have an MRI for this one, I don't believe. So AO spine would give this a 9, which would say, okay, complete burst fracture plus this distraction, posterior tension band disruption, nerve root injury, and then the modifier saying, okay, I don't have an MRI, but I'm saying this is posteriorly disrupted. So that would point you to operating, but most people don't need a scoring system probably to say that. T-Lex similarly would say, okay, burst fracture, posterior ligamentous injury disrupted. Again, I don't actually have an MRI, so I guess I can't say that definitively, but, and then 2 points for the neuro, so it would point you to operating. Load sharing classification, if we tallied it up for this one, again, it's a 7, so that would, per the McCormick paper, say either do a staged 1 up, 1 down with a subsequent anterior column operation, or do more points of fixation posteriorly. And I guess where I trained, we kind of were loath to do the corpectomies in these cases. It's obvious it's more straightforward, it's easier, it's faster to do all from behind. You can get a decompression really quick if you need to, and you're just be definitive. But at the obvious tax on this guy's long-term mobility. So I can certainly see this one going either way. If you're more comfortable and do a lot of these corpectomies in this context, or you like to do these, like for instance, a lateral corpectomy after a 1 up, 1 down. But I did the 2 up, 2 down, had a leak, as this frequently happens. Let's go to another one. So 32-year-old female, car accident, lower extremity paresthesias, severe back pain. All right, so now we're getting even more unstable. So CT showed this unstable 3-column fracture at T8. It's kyphotic angulation, coronal plane deformity. She also had other C-spine fracture. But good strength, but altered sensation. So she had an incomplete cord injury. And so, again, I'm a resident. I'm seeing this person in the ER. What do I tell? How do I formulate a plan for this person? How do I convey this to the attending on call? We could come at them with their score. So AO spine would say 13, so C-type or displacement dislocation. Morphology with an incomplete cord injury, modifier for the posterior ligamentous complex, say, okay, well, this is operative. Most people wouldn't need a score for that. T-Lex, again, similarly, translation rotation, ligamentous complex disruption, it adds up, incomplete cord injury to, hey, this is operative. Load sharing classification, when you tallied up for her injury, I gave it an 8, which, when you factor in the kyphotic angulation, would say 1 up, 1 down, you're risking it, hardware failure if that's all you do. It's certainly easy to justify in the thoracic spine as relatively less mobile as it is. So I gave her a longer construct posteriorly and corrected the coronal plane deformity in the process, decompressed the spinal cord. Another case, a 32-year-old rollover MVC in the ER was found to have this T10-11 fracture dislocation, complete spinal cord injury. So you don't need a scoring system to say that this is unstable, but if there was any wonder, you can still get a score from these scoring systems. AO spine would give it a 13. T-Lex would give it an 8. They would say operate, of course. Sharing classification doesn't really help. It doesn't really apply for once you start getting into these where it doesn't actually like cause a lot of comminution of the vertebral body itself. So there are certainly limitations if you're just trying to use the cookbook approach. Another case, a 22-year-old supermorbid obese patient, MVC versus tree. I told you I trained in Florida. We have a lot of obese people. So these aren't like super uncommon cases. This was a T11, kind of a distraction, kind of a bony chance sort of thing. Distraction injury, very unstable. AO spine would give you a number that would say, hey, this is operative. T-Lex, again, this is a highly unstable injury. This would be operative. And load sharing, again, doesn't really apply here in this context, but when someone's that heavy and they have that unstable of an injury, most people probably would not do just a one up, one down. I didn't. Just a couple other things that we run into. Maybe I don't see so much in my active duty population, although certainly I'll see this in the veteran population that can factor into how you approach thoracolumbar injuries. So DISH, 83-year-old taken to the ER after a car accident, had a chest injury, was intubated, and then got 2 scans, one before intubation, or one before the chest tube, one after. And I was called after I was on call after the second scan got done. So this is just somebody who initial scan didn't show any problem, and the person is guarding after their initial injury, and they're maintaining their alignment, and then now they've gotten a chest tube, they've been intubated, they're relaxed, no longer guarding. Lo and behold, they have this huge lever arm across their thoracic spine, and no longer guarding, they have an unstable injury, and they're able to fish mouth. I've seen a number of patients come out of an MRI scan with a severe spinal cord injury in this kind of a context, and I know I'm not alone in that. So AO spine would say, with this kind of an injury, it's unstable. T-Lex, if you count it up, same thing. Load sharing doesn't really apply, like I said, but there's no tax for taking multiple points of fixation in someone like this. Like you said, you're dealing with a really long lever arm. The bone's already fused well above and well below anteriorly, so nothing's stopping you from adding more hardware and really bolstering that construct. Ankylosing spondylitis, I think of it as much the same way from how this would affect your approach to a thoracolumbar injury. So 74-year-old walking, his dog tripped him. This was just a fall from standing, and had this T11-12 fracture dislocation sort of thing, or just unstable spine fracture. And I want to say this scan was done in Daytona, and I was on call and they sent him to us, because I wouldn't have gotten an MRI. If you see someone like this, from a resident standpoint, right? If you get a CT scan and you see an injury and you can see that they got ankylosing spondylitis or auto-fused, what have you, you just have to be careful when someone lays flat in a scanner. So we would, as a resident, we would go down and position them ourselves if we're worried about that. So if you tally up the points for them, AO spine would say, hey, this is operative. T-Lex, same thing. Load sharing classification, again, not super helpful for this, but same concept. This is someone who has long lever arm, not the best bone quality, right? This bone's pretty brittle. This was a pretty bad fracture, just fall from standing. More points of fixation. And so that's our kind of general rule for AS or bad dish would be 3 up, 3 down. And that just kind of flies through I think, fairly logical approach to managing bread and butter thoracolumbar injuries. Were we going to do questions now, or?
We'll fill out questions
sure.
after this next one.
Okay. Yeah, you bet.